Hello, Namaste students. Today we will be discussing one interesting case from cardiovascular system. Here is a patient by name X, aged about 28 years. He is a laborer by occupation and he is hailing from Maharashtra. The history is given by himself and it is reliable. Coming to the presenting complaint, history of breathlessness on exertion since last 3 months, history of palpitation since last 3 months, history of cough for the past 3 months. Then history of fever 3 months back. So I repeat, the presenting complaint, history of breathlessness and exertion since last 3 months, history of palpitation since last 3 months, history of cough for the past 3 months, and he had history of fever, one attack around 3 months back. So this is the presenting complaint. Now coming to the history of presenting complaint. First we will discuss about breathlessness, the history of presenting complaint. Breathlessness and exertion is there since last 3 months, which was insidious in onset, gradually progressive, and it has progressed from NYHA class 1 to NYHA class 2. It aggravates during sleep. When he goes to sleep after 2 to 3 hours, then he will get the breathlessness and release with sitting posture. So there is history of paroxysmal nocturnal dyspnea. And breathlessness also increases on climbing only to the first floor and also on getting up from a squatting position. Breathlessness releases with rest and it is associated with palpitation and dry cough. Breathlessness is not associated with swelling of limbs or there is no any history of wheezing. So coming to the elaboration of the breathlessness students, here he is having insidious onset of breathlessness which is gradually progressive, and from NYHA class 1 it has progressed to NYHA class 2. An important symptom in the history what he says is PND, paroxysmal nocturnal dyspnea, which indicates left heart is involved here. Left heart is failed. So what is the mechanism of orthopnea and PND? As I discussed in the general examination, in orthopnea, the blood from the system circulation will enter the pulmonary circulation and diaphragm will move less while lying down. Patient is lying down. These two mechanisms will come into picture in orthopnea. Orthopnea is breathlessness and lying down. In PND, the same two mechanisms will come into picture. So what is PND? Patient will go to sleep around 9 or 10 o'clock. After 2 or 3 hours, he will get up with the breathlessness. The same two mechanisms will act in PND plus another two mechanisms. During sleep, the respiratory center is less responsive to hypoxia and hypercarbia, and catecholamine support to the cardia is very less during sleep. So this patient has history of PND, and NYHA class 1 to class 2 it has progressed. How do you classify NYHA classification of breathlessness? NYHA classification of breathlessness is NYHA class 1 is breathlessness on unaccustomed activities, for example lifting the heavy weight. NYHA class 2 is breathlessness on accustomed activities, for example walking from here to the bus stop. NYHA class 3 is breathlessness on less than accustomed work, for example doing daily activities, cooking, doing brushing, doing bedding, these kind of things. And NYHA class 4 is breathlessness on lying down, that is orthopnea. Which are the other modes of assessment of breathlessness? Especially for respiratory breathlessness, you have modified medical research council MMRC grade of breathlessness. The grade 0 is breathlessness on a severe exertion. Grade 1 is breathlessness on hurrying on a level ground or walking up the hill. Grade 2 is breathlessness if he walks at the same pace with his peer. Grade 3 is breathlessness on walking 100 yards. And grade 4 is breathlessness on doing daily activities. That is modified medical research council breathlessness, especially for respiratory breathlessness. Which are the other grades of breathlessness which you can assess? That is Canadian Cardiological Society assessment of breathlessness based on a metabolic equivalence. One metabolic equivalent is equal to 3.5 ml of oxygen per kg per minute. Grade 1 breathlessness is breathlessness on doing only more than 7 metabolic equivalents. Grade 2 breathlessness is breathlessness on doing 5 metabolic equivalents, the work equal to 5 metabolic equivalents. Grade 3 is breathlessness on doing the work around 2 metabolic equivalents. And grade 4 is breathlessness less than 2 metabolic equivalents. So more than 7, more than 5, more than 2, less than 2. Canadian Cardiological Society of Assessment. Sorry, this is specific activity scale what I told. More than 7, more than 5, more than 2 and less than 2. Specific activity scale. Okay, Canadian Cardiological Society of Breathlessness uses the blocks. One block is equal to 528 feet. So Canadian Cardiological Society grade 1 is breathlessness on a severe exertion. Grade 2 is breathlessness on doing the more than 2 blocks. One block is 528 feet. Grade 3 is breathlessness, where you will get breathlessness only while walking 1 to 2 blocks. And grade 4 is breathlessness on taking rest. So specific activity scale uses the metabolic equivalents: more than 7, more than 5, more than 2, less than 2 metabolic equivalents. Canadian Cardiological Society will use the blocks, how much blocks you can walk then when you develop the breathlessness. Then you have a NYHA classification and modified medical research classification of breathlessness. And once it comes to the breathlessness, you have to ask whether the breathlessness was sudden in onset. The sudden onset of breathlessness you get in acute severe asthma, left ventricular failure, pulmonary edema. These are the two common conditions. The other conditions: acute severe asthma, pulmonary embolism, and foreign body inhalation in a child. So sudden onset of breathlessness, acute severe asthma, left heart failure, foreign body inhalation in a child, pulmonary embolism, and tension pneumothorax. Then if the breathlessness is insidious onset and gradually progressive, then you think of a COPD, interstitial lung diseases, where they start insidious and gradually progresses. And if breathlessness comes intermittently and relieves, then you think of bronchial asthma, where if you take the medication, the breathlessness will come down. So these are elaborate and evaluate the breathlessness. And this patient has breathlessness, progress from NIH class 1 to 2 with association of paroxysmal nocturnal dyspnea. Okay, next. The next complaint which he had was palpitation. So let us come to the palpitation history elaboration. Palpitation is there since the last 3 months. It was sudden in onset, non-progressive, and it aggravates while during exertion and lifting heavy objects. It is not associated with any drug intake, and it is associated with cough and breathlessness on exertion. Release with taking rest and not positional. So I'll repeat. Palpitation is there since for the last 3 months, which is sudden in onset and non-progressive. It aggravates during exertion, lifting heavy weights, and it is regular. When I asked him to tap and show on a book, when he showed it, it was regular. And it is not associated with any drug intake. That is important because some other drugs can produce palpitation. And it is associated with cough and breathlessness on exertion, and palpitation release with rest. And it is not positional. Now, how to elaborate the palpitation history? What is palpitation? Palpitation is abnormal awareness of one's own heartbeat is palpitation. Palpitation, if there is a sudden change either in the rate or rhythm, you get palpitation. Sudden change in the rate or rhythm, you get palpitation. So palpitation can be sustained or intermittent. The intermittent palpitation you get because of atrial premature contraction or ventricular premature contraction. The sustained palpitation can be regular or irregular. The irregular sustained palpitation you get in atrial fibrillation, whereas a regular sustained palpitation, supraventricular tachycardia and ventricular tachycardia. The positional palpitation you get in atrial myxoma and mediastinal tumors, the positional palpitation. Then there are some other conditions which can produce palpitations like smoking, the tobacco chewing, alcohol intake, cocaine, amphetamine, atropine, then endocrinological causes like thyrotoxicosis, pheochromocytoma. Then all the high output states like anemia, beriberi, pregnancy, aortic regurgitation, valvular regurgitation, mitral regurgitation, aortic regurgitation, ventricular septal defect, patent ductus arteriosus, where there is a high output states, you can get palpitation. Palpitation, if it is due to psychological causes, usually it will be prolonged more than 15 minutes. In 41% of the patients, cardiovascular disease is the cause of palpitation. Psychogenic cause will be in another 31% and miscellaneous in the other causes. So this is about palpitation, and this patient has palpitation, which is regular and sustained. So which is the next symptom he is having? Cough. So let us come to the elaboration of cough, what this patient is having. Cough is present since last 3 months. It is insidious onset and gradually progressive. The cough is dry cough. Here it is not productive. Very important thing, it is a dry cough. It aggravates during lying down position. Whenever he lies down during night times, at that time the cough comes dry cough and release with the sitting posture. And it is associated with breathlessness on exertion and palpitation. So cough is present since the last 3 months and it is not associated with any wheezing or diurnal variation or any drug intake. So I repeat, cough is present since last 3 months, insidious onset and gradually progressive. It is a dry cough, whatever he is having. aggravates while lying down position, relieves with sitting posture. And cough is associated with breathlessness and exertion and palpitation. It is present since last 3 months and not associated with any wheezing, diurnal variation, or not associated with any drug intake. So cough, only if it is productive, then you lose the other symptoms, the amount of sputum production, the color, the postural variation, whether he is associated with any foul smelling sputum. Here he has only dry cough, that to cough on lying down. Probably this dry cough is manifesting as one of the criteria for the left heart failure. Whenever he lies down, he is getting a dry cough. And that to night time, whenever he lies down, he is getting a cough. The nocturnal cough, the differential diagnosis are congestive heart failure, bronchial asthma, chronic bronchitis, aspiration, tropical eosinophilia, and postnasal drip. So the nocturnal cough is aspiration, postnasal drip, tropical eosinophilia, heart failure, chronic bronchitis, you will consider as the differential diagnosis. So this patient has coughed since last 3 months, which is dry, aggravates on lying down position. Probably a manifestation of a heart failure, because on lying down only he is getting the cough which is aggravated. Suppose if he has a large amount of sputum production which aggravates some postural variation, then you can think of bronchiectasis and lung abscess, because the secretion will come and irritate the normal mucosa and that will produce the cough. So the next symptom, whatever the patient is, so we discussed about breathlessness, palpitation and cough. Okay, the next symptom was fever, he told. Patient, he told he was apparently normal 3 months back when he noticed fever, which was sudden in onset, high grade, and it lasted for 2 to 3 days. So it was associated with cold and cough, not associated with any rash, joint pain, and it was not associated with any aggravating factors, and it relieved with the medication. So I repeat, the patient had one attack of fever around 3 months back, which was last for 2 to 3 days, associated with cold and cough, and it relieved with medication. So probably he had an upper respiratory tract infection around 3 months back. The one attack he had, probably a fever with a cold and cough. So these are the main 4 symptoms, students: fever, cough, breathlessness, and palpitation, and I elaborated everything. So breathlessness, I want to make you rectify that. The specific activity scale is a metabolic equivalence, and Canadian cardiology classification, they measure in terms of blocks. Okay. So this is the history of presenting complaints, students. Now, what are the other complaints? There is no history of syncope, so which is another cardiological symptom. He doesn't give history of any syncopal history. There is no history of weight loss. He didn't give any history of weight loss. And there is no history of swelling of both the legs. He didn't give history of swelling of both the legs. No history of any bluish discoloration of the lips or the soles or the palms. So he has not noticed any cyanotic change in the body, whether in the palms, soles, okay, or in the mucous membrane. Past history, now let us come to the past history. No history of similar complaint in the past. No history of any prolonged fever or hospital admission in the past or childhood, and he doesn't give history of any joint pain in the childhood. Why that history is important is because past history of rheumatic fever, as I remember, only joint pain, because everybody will get the sore throat and pharyngitis. We can't remember the number of attacks of pharyngitis which we had since childhood. But joint pain is such a severe pain in rheumatic fever, definitely they'll remember that symptom. So you have to ask history of past history of joint pain to whether they had a rheumatic fever or not during their childhood. There is no history of tuberculosis or bronchial asthma, and no history of any previous surgeries. Patient doesn't give history of any repeated respiratory tract infections during childhood. This history is very important because in a congenital heart disease, left to right shunts, they give history of repeated respiratory tract infections during childhood, but this patient doesn't give. So what's the criteria to have? Yes, there is increased recurrent respiratory tract infection. The criteria is if the patient has pharyngitis or tonsillitis, the number of attacks more than 3 per year, or if the patient experiences rhinitis more than 5 per year, or otitis media more than 3 for 6 months, or more than 4 per year. So I repeat, pharyngitis or tonsillitis more than 3 per year, or more than 5 rhinitis per year, or otitis media more than 3 for 6 months, or more than 4 per year. It is the definition of repeated respiratory tract infection. That history is important because in left to right shunt lesions, patient will have repeated respiratory tract infections. Personal history, he takes a mixed diet and he has a tobacco chewing habit No other addictive habits apart from tobacco chewing habits. Bowel and bladder is regular. Sleep is disturbed due to the dry cough, whatever he is having. He lies down. At that time, he develops breathlessness. His sleep is disturbed. And there is no high risk behavior also. He doesn't give any history of high risk behavior. Family history. He is born out of a non-consanguineous marriage. And he has one brother who is not suffering from any such illness, whatever he is suffering from. And he has two children, both are females. One is 3-year-old, another is 1-year-old. And there is no history of similar complaints in the other family members. All are healthy. Treatment history. He is taking treatment for the cough, and also there is no history of any monthly injections. This history is important because if the patient is a non-rheumatic heart disease, the monthly injection of Penidur injection history they will give if they are taking. That history is important. So these are history students in this patient. Here is a patient who came with history of breathlessness since last 3 months, history of palpitations since last 3 months, and history of dry cough since last 3 months, which aggravates on lying down. And probably one attack of fever he had 3 months back. So what are the differential diagnoses we will consider? That too with history of PND. Once there is history of PND, heart is failed due to what? In Indian circumstances, first we'll go one by order. First we'll consider anemia only because the malnutrition is so rampant in India. Probably anemia can produce breathlessness and palpitation is a possibility. But anemia per se producing heart failure is very rare according to the Hurst. Unless there is some cardiological lesion per se, anemia per se won't produce a heart failure. So that is one diagnosis. Probably we can consider anemia as a diagnosis. Can be a thyrotoxicosis. There is no history of weight loss. There is no history of sweating. But still he has breathlessness and palpitation. But he is PND and orthopnea. So again, thyrotoxicosis going in producing a heart failure, then you have to think like that. A second diagnosis, probable. And the third diagnosis in this age group around 25-year-old, okay, with the left heart failure, we have to consider congenital heart disease as one of the differential diagnoses. So the congenital heart disease, left to right shunt, atrial septal defect, ventricular septal defect, patent ductus arteriosus is a possibility. Then one of the diseases which are present at this age group, congenital heart disease, is bicuspid aortic valve. They present usually in the second decade. They can manifest like aortic stenosis or aortic regurgitation. Of PDA, ASD and VSD, PDA depending upon the shunt, magnitude of shunt, it can present at any age group. Ventricular septal defect again depends upon the physiology, depends upon the magnitude of the shunt, whether it is restrictive, non-restrictive. Depending upon that, they manifest at different age group, infancy or adult age group. And atrial septal defect, it can manifest in the 4th decade with the atrial tachycardia, and they can have breathlessness. Depending upon the magnitude of the lesion, they can have breathlessness either in the 3rd decade, 4th decade. In the 4th decade, they can come with palpitation with atrial arrhythmias. And one more important differential diagnosis in our Indian subcontinent is rheumatic heart disease. Usually rheumatic fever comes in the age group of 5 to 15 years of age group, and rheumatic heart disease develops after another 10 to 20 years, the rheumatic heart disease develops. But in India, the virulent strains are there, so even after experiencing the rheumatic fever, within 3 to 5 years, even sometimes within 2 years, rheumatic heart disease can develop. So definitely there is a possibility in this case, rheumatic heart disease. Probably which valvular heart disease then you are thinking with this history, with palpitation and breathlessness. Could be a mitral valve, it could be a mitral stenosis, could be a mitral regurgitation, or even aortic valve disease also possibility. Could be aortic regurgitation. So these are the differential diagnoses you can consider in anemia. Thyrotoxicosis unlikely, but still. Then congenital heart disease could be a bicuspid aortic valve, ASD, VSD, PDA, and rheumatic heart disease. This is a history evaluation and discussion in this patient. Let us go to the examination and see probably what he is suffering from. Now coming to the examination by the students. So let us go to the general physical examination. He is conscious and oriented. His height is 170 centimeters. Weight is around 48 kgs. And then vitals, coming to the vitals. Temperature is 98.6 degree Fahrenheit. Pulse, the rate is 100 beats per minute. It is a regular high volume pulse. And it has a collapsible character. So how do you look for the collapsible character? So I will show how do you look for collapsible character. The patient, you have to hold the hand. So students, for the collapsing pulse, the left hand you have to keep over the forearm. With the right hand, you have to feel the pulse, okay, the radial artery pulse. And then suddenly you have to lift the hand above the level of the heart, okay. Then you can feel the pulse through the muscles in this left hand, okay. Right. So that is how you feel for the collapsing pulse. So you have to feel the pulse and suddenly lift above the level of the heart, okay. So, okay, bye. So this patient has a collapsing pulse. All the peripheral pulses are felt normally, okay, and there is no radial or radiofemoral delay. There is no radial or radiofemoral delay. The condition of the vessel wall is normal. Coming to the blood pressure, the blood pressure in the upper limb is 100 by 40 in the right arm. In the left arm, 110 by 50, and in the lower limb, 180 by 150. So he has a high output signs like collapsing, and even the Hill sign is also a positive here. The lower limb BP is around 180 by 100. Okay, so he has high output state. What is the cause? Let us see after the examination for his high output state. The respiration is 21 cycles beats per minute, and it is abdominothoracic. Now coming to the other general physical examination, there is no pallor, there is no icterus, no cyanosis, no lymphadenopathy, and there is no edema. Okay. So next is, in these sort of cases which you are considering the differential diagnosis, a rheumatic heart disease, a congenital heart disease, then some top to bottom, some of the general physical examination you have to look. So what are the general physical examination or the syndromes which you look whenever you suspect left to right stent lesions in this sort of cases? The common syndrome is the Down syndrome, which can produce the ASDs, VSDs. What are the features of a Down syndrome which you see from top to bottom? They'll have palpebral fissure, okay, which is slanted. That means normally palpebral fissure is horizontal. It will be slanted like this. The lateral part will be upward, the medial part will be downward. The mongoloid. Palpebral fissure will be slanted. Then there will be one extra fold of skin medially, that is epicanthal fold can be there. Epicanthal fold. Then whitish iris circling around the pupil, okay, brush field spots can be there. The nasal bone can be a flat. Macroglossia can be there. Then both the angles of the mouth can be sagged down in a Down syndrome. Then there will be a single palmar crease called as a simian crease in the hand. So epicanthal fold, slanted palpebral fissure, brush field spot, flattened nasal bridge, the sagging of the mouth, macroglossia, and simian crease. These are some of the important features of a Down syndrome. I have shown the diagram. I will explain when telling theory. The Down's diagram I have put it. Then the other two syndromes which you look is Patau syndrome and Edwards syndrome. Patau syndrome, they will have polydactyly, flexion deformity of the hand, cleft palate, cleft lip, microcephaly, holoprosencephaly. What is holoprosencephaly? The forebrain, it fails to divide into two parts. That is holoprosencephaly. And they can have a single palmar crease and then low set ears in a Patau syndrome. Then Edwards syndrome features. In Edwards syndrome features, the finger will be a fist formation of the hand. Hand will be in a fist formation. The occiput will be very prominent and micrognathia will be there. And rocker bottom foot. Rocker bottom foot is calcaneum will be hugely enlarged with a convexity of the heel part. That is rocker bottom foot. So fisted fingers, micrognathia, prominent occiput and rocker bottom foot. Edwards syndrome. Then here there is a high output state. One of the congenital heart disease which can produce that is ventricular septal defect, a left to right shunt. There are some syndromes associated with ventricular septal defect which you have to see top to bottom in these sort of cases. Which are those syndromes which you will see top to bottom in these sort of cases? Cri-du-Chat syndrome. They will have a cat cry, Cri-du-Chat syndrome, microcephaly, mental retardation, and antimongoloid palpebral fissure. Antimongoloid is, the mongoloid is the medial part of the palpebral fissure is lower part, lateral part is upper part. The antimongoloid is, the medial part will be upper one, the lateral part of the palpebral pressure will be lower down. So, Cri-du-Chat syndrome, cat cry, antemangular palpebral fissure, microcephaly, mental retardation. Then Klippel-Feil syndrome, where they will have a short neck, one of the craniovertebral junction anomaly, scoliosis, and Springle anomaly. Springle anomaly is the shoulder will be malformed with the elevation of the scapula on that side. Klippel-Feil deformity. Then Cornelia de Lange syndrome. Cornelia de Lange syndrome is the ventricular septal defect. Micromelia is very short limbs and mental retardation. Cornelia de Lange syndrome. Then Cornelia de Ungermann syndrome. In this, they will have ventricular septal defect. They will have asymmetrical limb hypoplasia, one side long, one side short. Then they will have a large pores in the skin and punctate mineralization. Cornelia de Ungermann syndrome. Then Apert syndrome. Apert syndrome, they will have cranial synostosis. You have a sutures in the bone, cranial bone, that won't be there, that will be fused. Cranial synostosis. And the mid part of the face will be malformed. And they will have syndactyly. Apert syndrome. Then water syndrome. Water syndrome vestibular anomalies. That is V. A is anal atresia. TE, tracheoesophageal fistulas. R is renal and radial anomalies. So that is water syndrome. Then fetal alcohol syndrome. Fetal alcohol syndrome, they have ventricular septal defect, microcephaly, mental retardation and physical growth retardation, and palpebral fissure will be very short in them. So microcephaly, palpebral fissure very short, mental retardation, growth retardation, and ventricular septal defect. Fetal alcohol syndrome. Then you have velocardiofacial syndrome. As I told in ASD discussion, they have transposition of great vessels, ventricular septal defect, pulmonary atresia, and Fallet's tetralogy. In velocardiofacial syndrome, the upper part of the jaw will be very well hugely developed. The lower part of the jaw will be very less developed, along with the prominent nose and a thin upper lip. So they can have VSD, pulmonary atresia, Fallet's tetralogy, truncus arteriosus. So these are some of the syndromes: Down syndrome, Patau, Edwards, Klippel-Feil syndrome, Vater, Apert, Cornelia de Lange, then Cornelia de Ungermann syndrome, fetal alcohol syndrome, velocardiofacial syndromes. So top to bottom, if you suspect any of these left to right side lesions, whether we have those features, you have to look in these congenital heart disease patients. Then you are suspecting rheumatic heart disease. So any rheumatic activation signs are there, like subcutaneous nodules or erythema marginatum, you have to look at it. In any cardiac patients with history of fever of pyrexia of unknown origin, if they have a fever, you have to look for signs of infective endocarditis, like osseous nodules, which are painful nodules in the pulp, splinter hemorrhages in the nails, Janeway lesions, and anemia. These are some of the important features of infective endocarditis which you have to look in any case of either RSD or congenital heart disease. So this is top to bottom what you look relevant to in this case. So this patient is not having any of the syndromes which are associated with congenital heart disease. Okay, neither he has any signs of infective endocarditis nor any signs of rheumatic fever is there. Okay, students, now let us go to the examination of cardiovascular system proper. Now coming to the inspection. So what are the things you see in the inspection? Okay, so whether is there any precordial bulge you will see. Okay, so this patient doesn't have any precordial bulge, especially in the cases which you are discussing, which you are thinking here, left to right shunt lesions, atrial septal defect. If there is a right ventricular hypertrophy before the onset of puberty, it can produce RVH and it can produce a precordial bulge. Then you have to look for apical impulse. So apical impulse, you have to look tangentially, either like this, or you have to go to a foot end and then you have to look for the apical impulse. Here there is no visible apical impulse. Okay. Probably it may be behind the rib. So let us see on palpation where is it is situated. Then any visible pulsations in the suprasternal, left second intercostal space or epigastric region is there, you have to see. Suprasternal pulsations you get in aortic regurgitation, aortic aneurysms and thyrotoxicosis and thyroidea artery pulsations. Left second intercostal space pulsations you get in pulmonary hypertension, if at all if it is there. Then epigastric pulsations, the causes are left lobe of liver, aortic aneurysm pulsations and RV impulse, right ventricular impulse. Then any JVP is raised, you have to see. In this case there is no rise of JVP. And any other scars and sinus are present in the precordial region, you have to see. Are any left parasternal pulsations visible also, you have to see. The left parasternal pulsations could be due to the RV enlargement or LA enlargement. So there is no striking inspectory findings in this patient. Okay. So you have to ideally look for the apical impulse pulsations inspection, suprasternal, left second intercostal space pulsations, epigastric pulsations and left parasternal pulsations. This is the inspection in this case. Now let's go on to the palpation. So here the chest wall shape appears symmetrical. There is no precordial bulge. Apical impulse is not visible and there is no visible epigastric pulsations or parasternal pulsations seen in this patient, and there is no scars or sinuses or even there is no rise JVP. Now coming to the palpation. So palpation, apex beat you have to feel. Apex beat, you have to feel for the apex beat. As I told, apex beat you have to localize with the tip of the fingers. Okay. And then if any thrill, then you will use the base of the fingers. And for any heave, you will use the base of the hand. So feel for the apex beat. Here it is felt here. So it is second space, third space, fourth space and fifth space. So it is in the mid clavicular line. It is just in the mid clavicular line. You have to locate the apex beat. Then you have to look for any parasternal heave is there or not. How do you look for parasternal heave? You have to use the ulnar border of your hand. Look for the parasternal heave. The grade 1 is just inspection, you are not able to feel it. The grade 2 is you will feel it but you can obliterate it. Grade 3 is you cannot obliterate. That is a parasternal heave, Ames grading. Here there is no parasternal heave. Then you have to look for any palpable P2. So this is the first space, second space. In the second space you have to look for any palpable P2 is there. Here there is no palpable P2. Palpable P2 indicates pulmonary hypertension. And in this case, you are thinking left to right shunt lesion. So other important palpable finding what you have to look in left parasternal region is whether there is any thrill is there in left parasternal region. So this is the left parasternal third and fourth intercostal space. So there is a thrill felt here. A systolic thrill left parasternal region. In the left parasternal region, third and fourth intercostal space. The thrill in a serious examination indicates organic lesion. It localizes a lesion and the grade is 4. Then epigastric pulsations you have to feel for it. If it is there, inspection it is not visible. So the finger, when you press it, if it comes and touches the tip of the finger, it is RV apical impulse. If it touches the pulp of the finger, it is aortic pulsations, abdominal aortic pulsations. If it touches the left side of the thumb, it is left lobe of the liver. So you have to localize the apical impulse, parasternal heave, palpate P2, any thrill felt you see, and epigastric pulsations you feel. So one important finding what we got is there is a thrill in the left third fourth intercostal space, a systolic thrill. So it localizes the lesion is there. So palpation, apical impulse is felt in the left fifth intercostal space, okay, and the character whatever the apical impulse which is felt is here it just lifts the finger and it is going down. So it is hyperdynamic, okay. Whenever you feel the apex beat, the character you have to define it. So hyperdynamic apical impulse is it will lift your finger and it will come down, whereas a heaving apical impulse will lift your finger, stays there for some more time and then comes down. Cardiac systole time will be more than 2/3 in a heaving apical impulse or a sustained heave, whereas in hyperdynamic apical impulse, it is between 1/3 to 2/3 of the cardiac systole the duration. Amplitude is increased both in ill sustained and a sustained, that is hyperdynamic ill sustained, a forceful or a sustained where the amplitude is also increased, but the duration is increased only in sustained but not in a ill sustained or a hyperdynamic apical impulse. Whenever you get a hyperdynamic apical impulse, you will consider regurgitation lesions like AR, MR or a left to right stent lesions like ventricular septal defect is a possibility. Whenever you get a sustained heave, you think of aortic stenosis, systemic hypertension as the cause of sustained heave apical impulse. A tapping apical impulse will just comes, touches and goes, you get in mitral stenosis. So here there is a hyperdynamic apical impulse. Okay, it is just in the midclavicular line. Normally it is 1.5 cm medial to midclavicular line, but here it is in the midclavicular line. There is thrill felt in the left, third and fourth intercostal space and there is no palpable P2. This is the palpatory findings. Now let's come to the percussion. Percussion of the heart has only two importance. One is the base of the heart percussion and right side of the heart percussion. Base of the heart percussion, you will do light percussion. Normally the cardiac dullness is present in the left third intercostal space. If it is in the left second intercostal space, that indicates pulmonary hypertension. Now let us do the light cardiac percussion. So I will do light percussion. It is dull, third space. This is normal. Suppose if second space becomes dull, that indicates pulmonary hypertension or pericardial effusion. How do you percuss right heart border? Right heart border is percussed by, first you have to percuss the liver dullness, it is normally in the fifth intercostal space, then go one space above, then percuss parallel to the sternal border. So I will percuss now. Second space, third space, fourth space, fifth dull. Now go one space above, then start percussing laterally. Now the dull node is corresponding to the right sternal border. That is normal. Suppose if the dullness is away from the right sternal border, then you will think of pericardial effusion or aneurysm of the ascending aorta. So these two borders are important, base of the heart border percussion and right heart border percussion in cardiovascular system examination. Here the cardiac borders are normal, the base of the heart is third space is dull to percuss and right heart border corresponding to the right sternal border dullness. Okay. Now let us come to the auscultation. I will auscultate all the areas. Okay. Mitral area, tricuspid area, aortic area, pulmonary area. Because I got a thrill in left, third, fourth intercostal space, I have to auscultate that area in this patient. Then one more, because I consider second decade in this breathlessness and palpitation aortic lesion, I have to auscultate for aortic regurgitation murmur also. So how to look for aortic regurgitation murmur? So now because this case is in second to third decade, came with breathlessness and palpitation. One of the DD we consider was bicuspid aortic wall, and in second decade they can come with aortic stenosis or aortic regurgitation. So I have to look for AR murmur in this case. How to look for AR murmur? I'll auscultate in the neo-aortic area, left third intercostal space, and ask the patient to put a deep expiration and then hold the breath in expiration. So let us see now. Sasle, Sastoda, recognize. Okay. So that's how you auscultate for AR murmur. So students, I'll summarize the auscultatory findings in him. In a mitral area, S1 and S2 is heard, there is no murmur. In a tricuspid area, S1 and S2 is heard and there is no murmur. And in pulmonary area and aortic area, S2 is heard and there is no loud P2 or no loud A2. I got a thrill in left, third, fourth intercostal space, which is a systolic thrill, and at the same area there is a pansystolic murmur of grade 4 to 5 intensity. So a grade 4 to 5 intensity left, third, fourth intercostal space, there is a pansystolic murmur felt. And in neo-aortic area, there is no EDM murmur also heard, which suggests aortic regurgitation, it is not there. So very important hallmarks sign what I got is thrill in left, third, fourth intercostal space and a pansystolic murmur at the same area, left, third and fourth intercostal space. This is the auscultated findings. So now students, what are the differential diagnoses we considered at the end of the history? We considered anemia, thyrotoxicosis, ASD, PDA, VSD, and bicuspid aortic wall, rheumatic heart disease. These are the DDs we considered. What are the positive findings we got in examination? Inspection was almost normal. Palpation, apical impulse is just slightly shifted laterally, which is hyperdynamic. There is a thrill in left, third, fourth intercostal space. Percussion, normal. Auscultation, a pansystolic murmur in the left, third, fourth intercostal space. Now, with this cardinal sign, what are the DDs we considered? We can rule out all the differential diagnoses. This you get only in ventricular septal defect. And that can explain his symptoms also. There is a high output state, pulse pressure was very wide, BP was very wide, collapsing pulse was there. We have palpitation, which indicates high output state due to VSD. Breathlessness, probably LV is failing in him. Cough, dry cough because of a left heart failure. So everything could be explained with that whatever PSM is having in the left, third, fourth intercostal space. So this is a classic case of ventricular septal defect, which will be kept for both undergraduates and postgraduate students. So you should never forget, left, third, fourth intercostal space, a thrill and a PSM is the hallmark sign of ventricular septal defect. Now coming to the discussion of ventricular septal defect. Ventricular septal defect, students, 90% is membranous. 80 to 90% is membranous. Muscular defects are divided into three types. One is inlet, trabecular and outlet. Now how to understand that? So as I told students, 80% is membranous, the rest are muscular. Muscular is divided again into three parts. One is the inlet, trabecular and the outlet. Now see students, I am viewing, this is a septum. You consider my hand as a septum. This is the RV. This is the LV, for example. This is a RV, this is the LV. and here tricuspid valve is there. So the muscular septum which is just below the tricuspid valve is inlet VSD. Inlet VSD. Then the middle part is a trabecular VSD. Then you have a pulmonary artery here from the RV. Pulmonary artery goes to the lungs. The septum which is just below the pulmonary artery is known as infundibular VSD, outlet VSD, supracrystal VSD, subpulmonic VSD, doubly committed VSD. These are the different names for the infundibular VSD. So students, this is from the RV, this is LV. Here tricuspid valve is there. The just below the tricuspid valve septum, the muscular septum is the inlet. There are three types of muscular septum division. One is the inlet, the middle one is the trabecular, then the outlet. Outlet, pulmonary artery, the one which will be going from the RV, just below the pulmonary artery, which is the septum, that is the infundibular or a outlet or a supracrystal or subpulmonic or doubly committed ventricular septal defect. Okay. So three types of muscular defect: inlet, trabecular and infundibular. The inlet VSDs are around 5 to 7%. The trabecular VSDs are around 8 to 15%. The infundibular VSDs are again around 7%. The muscular VSDs, most of them will close 90% within the 10 months of life. Then in phalanxectology, you get one type of VSD known as mall aligned VSD. What do you understand by mall aligned VSD? See students, I told, suppose if this is a muscular VSD, you have inlet, a trabecular and an outlet. The outlet VSD, which is just below the pulmonary artery, and the trabecular VSD, which is the middle part, they mall align. The infundibular VSD will come little anteriorly and little upwards it goes. And the trabecular VSD will remain wherever it is. So then both will mall align, producing a VSD in phalanxectology. It's a mall aligned VSD. Students, this is a muscular VSD. Then what is the membranous VSD? The membranous VSD abuts all the three: the inlet, the trabecular and the infundibular VSD. Surrounding here a membranous. Above that there will be a membranous VSD. So perimembranous VSD means it just extends a little part to the muscular VSDs. So membranous VSD will cover the inlet, the trabecular, the outlet VSD. I explained this again in the diagram in the theory. What are the different types, anatomical parts of VSD? So mall-aligned VSD you get in phalanxectology. So students, most of the VSDs will close by 1 year, 60% will close by 3 years, 90% will close by 5 years. There is one variety of VSD in the trabecular VSD that is called as a multiple sieve-like VSDs, which is called a Swiss cheese pattern. That Swiss cheese VSDs, they won't close, and inlet VSDs hardly close. Whereas infundibular VSD could be closed either by a prolapse of a tricuspid valve or a coronary valve or a non-coronary valve from the aorta. Okay. Then ventricular septal defect, what are the ways it can close? Either there can be a growth of the fibrous tissue, that is one way it can close, or there can be a prolapse of the tricuspid valve or the aortic valve into the septum. There can be aneurysm formation by which it can close the septum, or infective endocarditis can come and close the septum. These are the ways how a VSD can be closed: a fibrous tissue growth, prolapse of the tricuspid or the aortic valve, infective endocarditis can come and occlude it, or aneurysm may be formed. If an aneurysm forms in a ventricular septal defect, that is a source of infective endocarditis, a thrombus can be formed in the aneurysm which can throw embolism. It can produce blocks, cardiac conduction blocks. It can produce AR or TR, or it can produce RV outflow obstruction. These are the complications of aneurysms: thrombus with an embolism, infective endocarditis, conduction blocks, AR or TR or RV outlet obstruction. The whole VSD students, the physiology depends upon the magnitude of the shunt of the lesion and pulmonary vascular resistance. Please keenly listen now. There are 4 varieties of physiological derangements which can occur in ventricular septal defect. There are 2 restrictive types, 2 non-restrictive types. Restrictive means the pressure difference will be at that level, so the defect will determine the shunt. Non-restrictive means it will be very low, the shunt, so the magnitude of the shunt will be decided by the vascular resistance in the pulmonary vascular bed. Which are the 4 physiological types you can get in a ventricular septal defect? First is a small restrictive VSD. So in a ventricular septal defect, the defect will be very small and it is restrictive because at that junction the pressure difference will determine the flow from LV to RV. And here in a small restrictive VSD, the pulmonary artery pressure is normal, RV pressure is normal and pulmonary vascular bed resistance is also normal. The name which is given for this small restrictive VSD is Malady-Roger. RV pressure is normal, pulmonary artery pressure is normal, pulmonary vascular resistance is normal, and Malady-Roger is the name given for this small restrictive VSD. Next you have moderately restrictive VSD. Here shunt lesion will be little big, but still the shunt is determined at that level only between LV and RV. In a moderately restrictive VSD, RV pressure is increased, systolic pressure. Pulmonary artery systolic pressure is also increased. Pulmonary vascular resistance is low but variable. So students, RVSP is increased, pulmonary artery systolic pressure is increased, pulmonary vascular bed resistance is low but variable and it is moderately restrictive VSD. Then these are the 2 varieties of restrictive VSD. Then you have 2 non-restrictive varieties of VSD. So first is non-restrictive VSD where the pulmonary vascular resistance is increased but it is less than systemic vascular resistance. So here the VSD is very large here, very large, and pulmonary vascular resistance is increased but not more than the systemic vascular resistance. And RV systolic pressure will be equal to LV systolic pressure. So non-restrictive VSD. The 4th one is the Eisenmenger. A non-restrictive VSD where the pulmonary vascular resistance is more than the systemic vascular resistance and right to left shunt will occur there. Right to left shunt will occur. And there also RVSP will be equal to LVSP. These are the 4 varieties, physiological types of VSD students. So I repeat, a small restrictive VSD, moderately restrictive VSD. In a moderately restrictive, pulmonary artery systolic pressure, RV systolic pressure will be more, pulmonary vascular resistance is low but variable. Then you have a non-restrictive VSD where pulmonary vascular resistance is high but not more than systemic vascular resistance. 4th is a non-restrictive VSD with a Eisenmenger where the pulmonary vascular resistance is more than the systemic vascular resistance. These 4, the physiological variants of VSD, when I discuss the other things also very important students, you have to remember this. Now coming to the history of a VSD, how it comes on. The ventricular septal defect occurs, it's not related to any ethnicity, any race or any gender or a maternal age group or any order of the delivery. It is not related to any of these things. Not related to gender, race, ethnicity or the order of delivery or the maternal age. So history, how they usually come, how they manifest, all these four physiological variants of VSD. A very small restrictive VSD will be detected by a first well baby examination by a pediatrician. The smaller the lesion, the louder will be the murmur. But sometimes a faint early systolic murmur of a malady Roger can be missed by a doctor. In a malady Roger, very small VSD, you get an early systolic, not a pansystolic. Why? What is the reason? Because small VSD will be there, and when LV contracts, that small defect will close in the mid and late part of the system. That is why you get only early systolic. In a very small VSD, when ventricles start contracting, that will close the septum. So only early systolic you get in malady Roger. But still, that site, a very small VSD site, is a very high risk for infective endocarditis. Infective endocarditis, it usually doesn't occur before the eruption of the second tooth. Usually tricuspid valve is the area where the infective endocarditis will occur. The muscular VSDs usually won't produce infective endocarditis because the jet will go to the RV cavity. And these very small VSDs which are closed, sometimes they may show aneurysm later without any defect, because it will be closed by aneurysm, you may just show aneurysms later. So this is about small non-restrictive, small restrictive VSD or malady Roger. Next is moderately restrictive VSD. Moderately restrictive VSDs, initially there may not be murmur because pulmonary vascular resistance will take time to come down. At that time the shunt may not be that much between LV and RV, but once the pulmonary vascular resistance comes down after initial weeks, then left to right shunt will appear in a moderately restrictive VSD, and they may develop in the initial months heart failure, left heart failure. The mother may notice the thrill while touching the precordium, or she may notice the hyperdynamic precordium, the mother. Still, that moderately restrictive VSD is a site for infective endocarditis, and because of LV volume overload, they can develop heart failure. The baby will be restless, especially on lying down, sleeps very poorly, there will be a lot of perspiration and sweating, and if it sits, it feels comfortable, the baby. This is moderately restrictive VSD. And isotonic exercise they tolerate very well, because in isotonic exercise the peripheral vascular resistance reduces, so the more blood enters the aorta, the shunt reduces between LV and RV. So the child will tolerate the isotonic exercise little good. So next is non-restrictive VSD, the third variety, how it will come into picture. A non-restrictive VSD will present with a heart failure in the infancy because the shunt is very large, left-right. The baby will be having a poor growth, repeated respiratory tract infections, labored breathing, and baby will awake from sleep to feed vigorously, and then while feeding it develops cough, breathlessness, then again because of tiredness goes to sleep, then again gets up with the hunger, and again this cycle repeats. In some patients, the pulmonary vascular resistance may not come down at all in some of the kids. At that time, the left to right shunt won't be that much more, and examination will be deceptively normal in some patients in a non-restrictive VSDs, moderately non-restrictive VSDs. Now, in this non-restrictive VSDs, as time progresses, the pulmonary vascular resistance increases, and then right to left shunt develops, then they go for Eisenmenger. When they go for Eisenmenger, the shunt reduces from left to right, the murmur and physical findings also will reduce, and physical symptoms of heart failure also will reduce. They go for Eisenmenger with cyanosis. So students, in a non-restrictive VSD, the baby will present with heart failure symptoms in the infancy. The baby will get up from a sleep position, it will feed vigorously, only to develop cough and breathlessness, and again because of the tiredness it will go to sleep, then again gets up to feed it. This cycle continues. The baby will have a very defective growth development, repeated respiratory tract infections, labored breathing, perspiration, diaphoresis. As I told, some patients' pulmonary vascular resistance may not reduce at all. In them, the shunt between left ventricle and right ventricle will be very less, and sometimes the examination will be deceptively normal in some patients with non-restrictive ESDs, but very rare that is. Then, this non-restrictive ESD, as time goes, the pulmonary vascular resistance will increase. That will become more than a systemic vascular resistance, and then all the symptoms of heart failure will ameliorate, reduces, and patient will develop cyanosis and Eisenmenger complex. That is the fourth variety. Now, what are the clinical features of Eisenmenger symptoms? Erythrocytosis is a feature of Eisenmenger complex. Increased hematocrit, iron overload, or the viscosity doesn't predispose them to have any stroke. But less than 4-year-old children with cyanosis, if they have iron deficient erythropoiesis, they can develop cerebral venous thrombosis. And Eisenmenger also can produce right to left paradoxical embolism. Then they'll have acquired hematological bleeding abnormalities. Platelet will be less. Then they have acquired Van Willebrand defect, which will predispose them to mucosal bleeding like epistaxis, gingival bleeding, menorrhagia, or any traumatic bleeding may be increased. Whenever there is a trauma, bleeding may be increased. So menorrhagia, increase in the traumatic bleeding, gingival bleeding, epistaxis. There can be a pulmonary hemorrhage. There can be intrapulmonary hemorrhage producing a massive bleeding. That is the commonest cause of death in Eisenmenger complex. And they can have hemoptysis. Increased erythrocytosis will secrete because of the shear force, the nitric oxide and prostaglandin synthesis. And this increased NO and prostaglandins will dilate the tortuous blood vessels in the mucosa, which will predispose them to bleeding. Increased nitric oxide and prostaglandins, if they take sometimes, if they go to humid environment or if they take a hot shower, may produce syncopal attacks. The same erythrocytosis due to shear force due to increased NO and prostaglandins may dilate the coronary arteries, extramural coronary arteries, and may produce coronary ectasia. They will have increased uric acid, Eisenmenger complex patients, either due to a decreased renal excretion or increased production. There are both functional and structural abnormalities of the renal system. The functional abnormality is increase in the uric acid, and proteinuria is a functional abnormality. The structural abnormality is because of the increase in NO and prostaglandins, there will be dilatation of the capillaries and arterioles, glomeruli, and increased cellularity due to the increase of transforming growth factor and platelet-derived growth factor. Eisenmenger complex patients will have clubbing, and if they become pregnant, 50% is the maternal mortality rate. And if they do exercise, cardiorespiratory response will be very less. They develop tachypnea and breathless. The commonest cause of death is massive intrapulmonary hemorrhage or a hypertensive pulmonary trunk may rupture. These are the clinical features of Eisenmenger syndrome, what you get. So, this is the history of VSD. Now, coming to the general appearance. General appearance, so if they are in Eisenmenger, they can develop cyanosis. The growth can be little less, underdeveloped physical growth can be there. And because of hyperventilation, Harrison sulcus you may get in the coastal cartilage attachment of the diaphragm due to the repeated contraction of the diaphragm. Then as I told in the history, appearance you have to look for all the syndromes which I discussed, the Down syndrome, epicanthal fold, brushfield spots, palpebral fissure slanted, palmar crease, macroglossia, depressed nasal bridge, that's Down syndrome. Patau syndrome, cleft lip, cleft palate, polydactyly, microcephaly, holoprosencephaly, single palmar crease, and low set ears. Edwards syndrome, micrognathia, prominent occiput, rocker bottom foot, clenched fist, and low set ears. Then Cri-du-Chat syndrome, a cat-like cry, microcephaly, antemongoloid palpebral fissure. Antemongoloid means the middle part of the palpebral fissure will be high, the lateral part will be low. Microcephaly and mental retardation. Cri-du-Chat syndrome. Klippel-Feil syndrome, low hairline, that is short neck, scoliosis, springal deformity. Shoulder will be malformed with the scapula elevated. Apert syndrome, craniosynostosis, facial, the mid part of the face will be maldeveloped or hypodeveloped with syndactyly. Vater syndrome, vertebral anomaly, anal atresia, tracheoesophageal fistula, renal or radial abnormalities. Fetal alcohol syndrome, microcephaly, VSD, mental and physical growth retardation, short palpebral fissure, Cornell de syndrome, micromelia, there is a maldeveloped the arms and the legs and mental retardation. Connery-Hunnerman syndrome, where there is a asymmetrical limb hypoplasia will be there, along with large skin pores and punctate the calcification or the mineralization. And velocardiofacial syndrome, where there will be a prominent upper jaw, maldeveloped lower jaw, with the prominent nose, prominent face, which will be associated with tetralogy of Fallot, transposition of great vessels, pulmonary atresia, and VSDs. And other trisomies, the Patau syndrome, Edward, and Down syndrome will be associated with VSD, ASD, or PDS. So, those features whether the patient is having, you have to look from top to bottom. That is the physical appearance. Now, coming to the pulse. In a small non-restrictive VSD, pulse will be normal, like in a very small restrictive VSD. Moderately restrictive VSD, pulse will be brisk, like in him. You are having a high output, Hill sign is positive, collapsing pulse is there. Probably he is having moderately restrictive VSD. Pulse will be brisk. A non-restrictive VSD, where the pulmonary vascular resistance is more but lesser than systemic vascular resistance, they usually go for a heart failure, so you can get a pulses alternance. And in the Eastern VSD, again the pulse is normal. So very simple, a small restrictive VSD pulse is normal, Eastern complex pulse is normal, whereas moderately restrictive VSD you get a very high brisk pulse, and non-restrictive VSD where pulmonary vascular resistance is more but lesser than systemic vascular resistance, when they go for heart failure you get a pulses alternance. That is about the pulse. Then JVP. JVP, in a small restrictive VSD, JVP will be normal. In a small restrictive VSD, JVP will be normal. Whereas, in a moderately restrictive VSD, that is the second variety, and a non-restrictive VSD where the pulmonary vascular resistance is more but lesser than systemic vascular resistance, you get prominent A wave and V wave. The fourth variety, when they go for Eisenmenger, there can be a wave, but A wave will be not that much prominent like in a primary pulmonary hypertension or a pulmonary stenosis, because there is a VSD which will offload the ventricular pressure to the LV Eisenmenger, but you may get a small A wave, little prominent but not that much prominent, like in a isolated pulmonary hypertension where there is no septal defect, because here when RV contracts forcefully, because septum defect is there, the pressure will dissipate to the LV in Eisenmenger complex. So very simple, small restrictive VSD, JP is normal. In the second variety, moderately restrictive VSD and a non-restrictive VSD, A and V are prominent. Eisenmenger, there may be a wave, but not a V wave. But A wave is not that much prominent. That is J wave. Coming to the precordial palpation in ventricular septal defect. Precordial palpation. Left third fourth intercostal space, you get a thrill if it is a small restrictive VSD. Left third fourth intercostal space, you get a thrill. If the VSD is infundibular, you may get a thrill in left first intercostal space. Because pulmonary artery, a little above. That is infundibular, other name is I told supracrystal, subarterial, subpulmonary, doubly committed, other names. Don't get confused. All are infundibular. You will get a thrill in the left first intercostal space. That is for a small restrictive VSD. For a moderately restrictive VSD, you get LV which is hyperdynamic, probably in this patient. Hyperdynamic LV apical impulse. And dilated pulmonary trunk because of more blood flow across the pulmonary trunk. And RV is not impressive in moderately restrictive VSD. Then third variety, non-restrictive VSD, again you get a LV will be hyperdynamic. Pulmonary trunk will be, we can feel the pulsation. And RV will have a pressure overload because pulmonary vascular resistance is more in third variety. That is non-restrictive VSD, third variety. And when they go for Eisenmenger, LV will disappear because right to left shunt. The LV apical impulse you won't get prominent in Eisenmenger complex. RV will replace the apical impulse because RV is enlarged. Apical impulse will be replaced by the right ventricle. So this is the palpation of a ventricular septal defect, palpatory findings. So pulse, JVP, palpatory findings. Next is auscultation. Auscultation, small restrictive VSD, you get early systolic murmur as I told because in the mid and late systole the septum will be closed by the ventricular contraction. You get a early systolic murmur, malady, Roger. And what VPC will do on this murmur? Very interesting. Ventricular premature contraction is a prematurely ventricle will contract. Because prematurely it contracts, it is not that much forceful. So the murmur will lengthen. Whereas after the pause, when there is a more blood enters the LV, that contraction will be forceful. So that will shorten the murmur. Because when forcefully it contracts, the septum closes, that's why. Understood. So a VPC will lengthen the murmur of a malady Roger. A post extrasystolic beat will lengthen the murmur of a malady Roger. And a small restrictive ESD, you get a early systolic murmur. And as I told, if it is a subinfundibular VSD, you may get a murmur in left first intercostal space, which will radiate to the clavicle and left side of the neck. If it is a infundibular VSD, because it is little higher. Then, in a moderately restrictive VSD and a non-restrictive VSD, because more blood is entering from the LA to LV, you will get a flow mid-diastolic murmur in mitral area. Apart from the PSM what you get in left third fourth space, you get a flow MDM in a mitral area in moderately restrictive and non-restrictive VSD with pulmonary vascular resistance high but lesser than the systemic vascular resistance. And the fourth variety in the Eisenmenger is right to left shunt and pulmonary hypertension. So what you get, that flow MDM at the LV disappears. Loud PT you get in a pulmonary area, and a Gram-Still murmur you may get because of pulmonary hypertension, and a short systolic murmur you may get in a pulmonary area. So loud P2, a short systolic murmur in pulmonary area, MDM in the mitral area disappears, and the EDM you may get in pulmonary area because of the Gram-Still murmur in Eisenmenger. So this is about auscultation. What are the ECG features and X-ray features? All the four types, physiological types of ESD. Very simple. In a small restrictive ESD, the ECG is normal. Now, moderately restrictive ESD, now the more blood is entering from LV to RA to pulmonary artery to LA and LV. So they will have LV volume overload features. LV volume overload, diastolic overload feature is reflected in the ECG by a tall T wave, Q wave and a tall R wave in V5, V6. And LA will be enlarged in the ECG. in a moderately restrictive VSD. In a non-restrictive VSD, still where they have not gone for Eisenmenger, where pulmonary vascular resistance is more but lesser than systemic vascular resistance, you will get LV enlargement, LA, RA enlargement, and even RV enlargement. So they will have a biventricular enlargement. The biventricular enlargement in the ECG is reflected by mid-precordial leads V2, V3, V4, equiphasic R and S waves. That is known as Cox-Vactal phenomena. Very important, students. In the V2, V3, V4, equiphasic R and S waves will be there, known as a Cox-Vactal phenomena. The biventricular hypertrophy is also reflected by prominent R wave in V1 and a tall R wave, tall T wave, tall Q wave in V5, V6. So this is in non-restrictive VSD, where still they are not gone for Eisenmenger complex. The last one is Eisenmenger complex. And once they go for Eisenmenger complex, this LV volume overload disappears because now not more blood entering the LV. So this diastolic overload, tall R wave, tall T waves, Q waves disappears. Instead of that, RV will be enlarged. So you get an R wave in V1, tall R wave in V1 and S wave in V5, V6. R wave in V1, S wave in V5, V6 in Eisenmenger complex. The axis in Eisenmenger complex and non-restrictive VSD could be a right axis deviation, and inlet VSD will have a left axis deviation. These are ECG features. Students, the four physiological derangements in VSD, if you understand, all the things are very easy to interpret. Unless you don't understand those four physiological types, you can't interpret the X-ray, ECG and other pulse JVP. Now coming to the X-ray features. Small non-restrictive VSD, chest X-ray will be very normal. It will be normal. Moderately restrictive VSD, X-ray will show pulmonary plethora. More blood is entering the pulmonary artery. Pulmonary plethora will be there. LA will be enlarged and LV will be enlarged. Whereas the non-restrictive VSD, even without going for Eisenmenger, if it is there, then all the chambers will be enlarged. LA, RA, RV, LV, everything will be enlarged. There will be a huge cardiomegaly. But once they go for Eisenmenger, RV will enlarge, LV will shorten. The size will reduce, LV size. Only pulmonary trunk will be dilated because of pulmonary hypertension, and RV will be enlarged in Eisenmenger complex. And pulmonary oligemia will be there once they go for Eisenmenger complex. Whereas in moderately restrictive ESD, pulmonary plethora will be there. Eisenmenger, pulmonary oligemia will be there. So X-ray and ECGs will give a clue at what stage the patient is in. Whether there is a moderately restrictive, small restrictive, or moderately restrictive or Eisenmenger, you can make out by X-ray and ECG features. Then echo will establish the diagnosis of ventricular septal defect, 2D echo. Then there are other two varieties which you have to know in ventricular septal defect, VSD with AR. VSD with AR usually develops in male patients. VSD will be there since childhood, but AR develops in the age group of 5 to 9 years. Usually you get in an infundibular VSD, is VSD with AR, because the right coronary cusp or the non-coronary cusp will prolapse and closes the ventricular septal defect, producing the AR. Then one more variety is Gerbold's VSD. Gerbold's VSD is left ventricle to right atrial connection. Gerbold's VSD, it resembles any other perimembranous VSD except some features. The murmur will be present since the birth. It is present in the utero also because there is a huge pressure difference between LV and RA. RA is very small pressure, so there is a huge pressure difference. It will be present since utero and birth, the murmur. RA will be hugely enlarged and they will have atrial arrhythmias because of the atrial enlargement of Gerbold's VSD. And RA will be disproportionately enlarged compared to the pulmonary trunk. and they'll have both LV and RV enlargement, the Gerbold's VSD. And if infected endocarditis develops in a VSD, sometimes a membrane can rupture which connects the LV to a RA, producing an acquired Gerbold's defect. So these two types of VSD we should know, VSD with AR and Gerbold's ventricular septal defect. Now, how do you manage the patient and what are the indications for surgery in a ventricular septal defect? If the shunt lesion between pulmonary and the system circulation is more than 1.5:1, you have to operate. And the ideal age for operation is less than 2 years. Less than 2 years is the ideal age to operate. And if the shunt lesion between pulmonary to system circulation is more than 1.5:1, you have to operate. So this is a discussion about the ventricular septal defect, students. So if you get the case, you should be ready to answer all the questions. Mainly the physiology you have to understand. If you understand that, it will be the pulse, JVP, examination, X-ray, ECG, everything will be easy. Now after the discussion, I have given the X-ray and ECG features. I will discuss in the theory. And on audio clip also I have given how the ventricular septal defect sound will appear. So go through that, then it will be a complete discussion about ventricular septal defect. Thank you. Hello students, in detail we discussed about a ventricular septal defect case. I want to discuss few X-ray features and ECG features and anatomy of the ventricular septum. Okay students, right. So this is the anatomy of the ventricular septum. So here you can make out the membranous one. The 80% of the VSDs are membranous. Okay, the rest 88% approximately will be the three muscular VSDs. The three muscular VSDs are divided into outlet VSD. This is the outlet VSD. Okay, this is a trabecular VSD, the light green. Okay, and this is the inlet VSD, the light blue color one. Okay, right. So these are all approximately 88%. Okay. So the membranous VSDs will usually close. Okay, 80 to 90% will close by the year 6 years. The inlet VSDs seldom close. Okay, and a multiple Swiss cheese pattern of the trabecular VSD is known as multiple small sieve-like VSDs in the trabecular VSD is known as Swiss cheese VSD. The Swiss cheese VSD seldom close. So you are viewing this from the right ventricular surface, students. Right ventricular surface. So this is a perimembranous. The muscular VSD, there are three types. Okay, or the outlet VSD. Outlet VSD is also known as subpulmonic, supracrystal, subarterial, subaortic, doubly committed. These are the different names for the outlet VSD, students. And this is a trabecular VSD, this is the inlet VSD. Multiple sieve-like structures in the trabecular VSD, okay, is known as Swiss cheese VSD. Okay, students, this is the anatomy of the VSD. And few syndromes associated with the ventricular septal defect. Down syndrome. So Down syndrome, what are all the features? Here you can see the slanted eyes, the fissure, the upslanting palpebral fissure, a low set ear will be there, and a short webbed neck will be there, short webbed neck. Okay, and the nose will be flattened nasal bridge, and in the eyes here you can see small typically white spots arranged in a ring called as a brushfield spots. And here you can make out the upper eyelid, the skin fold, epicanthal fold. The upper eyelid skin fold covers the inner corner of the eyes, epicanthal fold. There are few important points in the Down syndrome. Then also here you can see in the Down syndrome, the distance between the great toe and the other toes of the foot will be enlarged. So there are mental retardation will be there. Okay. Right, and they can have umbilical hernia, hypotonia, diminished muscle tone will be there. Okay, right, and short and broad hands. As I told, epicanthal eye fold will be there. Okay, right. Then they'll have congenital heart defects as we discussed detail while discussing the case discussion. VSD, ostium primum, ASD, they will have it. And as I told, big toes will be widely spaced. Next is Patau syndrome. So Patau, you remember life like all PP, most of the things. So P, polydactyly will be there, polydactyly. Cleft lip and cleft palate will be there, cleft lip and cleft palate. P, another polydactyly. And porencephaly. Porencephaly is the forebrain. It fails to divide into two parts, so porencephaly and clenched fist, clenched fist. So all PP you can remember. So you can tell the few points about the Patau syndrome. So same thing, Patau syndrome, they'll have the polydactyly and they'll have the microcephaly also, microcephaly. And the cardiac defects, as we told, they'll have ventricular septal defect and cleft lip and cleft palate. Then you have Edwards syndrome. In the Edwards syndrome, the important thing is the micrognathia. You can see here the mandible is very small and the occiput is very prominent. Occiput is very prominent, and you have a clenched fist. Clenched fist will be there, and this calcaneum is very prominent. Calcaneum is very prominent. You can see here prominent heel will be there. There are some of the important feature, okay, of Edwards syndrome. Now coming to the ECG features of ventricular septal defect. As I told in the discussion, ECG doesn't tell about the anatomical type of VSD, whether it is a infundibular or a muscular or membranous, but it will tell about the physiological aspects of the ventricular septal defect. You have a very small restrictive VSD where ECG will be normal. Then you have moderately restrictive ESD, okay, where there will be diastolic overload of the left ventricle. You will get Q waves in V5, V6, lead 1 and AVL, okay. Then you have a non-restrictive ESD where there will be a biventricular hypertrophy in a mid-precordial leads V2, V3 and V4. That is known as a Katz-Wachtel phenomena. Here in this ECG you can see that, okay, in the mid-precordial leads V2, V3, V4, V5, you can see equiphasic R and S waves. This is known as a Katz-Wachtel phenomena. Then once they go for Eisenmenger, what happens is again there will be RV hypertrophy. All this diastolic overload Q waves will get disappear. You will get R wave in V1, okay, with the pulmonary hypertension developing Eisenmenger. The axis also will become slightly right axis in Eisenmenger. Inlet VSDs will have a left axis deviation, that you should know. These are the ECG features of ventricular septal defect. Then the X-ray feature. X-ray feature again will tell the physiological aspect of the ventricular septal defect. In a very small restrictive VSD, chest X-ray will be normal. Then moderately restrictive VSD and a non-restrictive VSD will have pulmonary plethora with a cardiomegaly, like this. Here you can see. So there is a pulmonary plethora with a cardiomegaly. You can see. Once they go for Eisenmenger, there will be a pulmonary oligemia. You can compare the pulmonary oligemia here. See, this X-ray is pulmonary oligemia. This X-ray is pulmonary plethora. So in this X-ray, you can see the RV will be there. So the LV is lifted up. This is the RV forming an acute angle with the diaphragm. Okay, pulmonary oligemia. Then pulmonary trunk is prominent because of the pulmonary hypertension. This is chest X-ray of Eisenmenger syndrome. Okay, students, these are the ECG and X-ray features of the ventricular septal defect and few anatomical points and few syndromes. Okay, students. So this should be helpful in answering any question in ventricular septal defect. Thanks, students.